We are going to be doing the lumbar examination. We will start with inspection. Inspection requires the patient to have their shirt off and appropriately draped if a female. In inspection, you are looking for any structural abnormalities such as any scoliosis or kyphosis or any gross atrophy, as well as looking for any skin changes to include any erythema, any vesicles, or any tufts of hair which may be indicative of other disease processes. After inspection, we do palpation. Remember, it is a purposeful palpation, so we are specifically looking for any tenderness on the spinous processes, which may be indicative of bony pathology. Then that will be followed by the paraspinal musculature. And as you move on down, you're looking for the posterior superior iliac spines, the PSIS. And then you can move into the sacroiliac joint, looking for any discomfort in those areas. Once we have done inspection and palpation, we do range of motion. For range of motion, we ask the patient to forward flex as far as they can, noting any limitations or any pain with that. After forward flexion, we ask the patient to do extension. The same thing, looking for the degree of extension and if there's any discomfort. Next, we will ask the patient to do lateral side bend and rotation. To do this, I usually ask the patient to give themselves a hug and then perform those maneuvers, again, looking for any pain or limitation in range of motion. We have now completed inspection, palpation, and range of motion testing. Next, we would normally move into our strength or neurovascular testing, followed by special test. But to save the patient from getting up and getting down, we will do some special tests that take advantage of the patient standing. And so this would include the Trendelenburg sign, where we're looking for any weakness of the hip musculature. And to do the Trendelenburg sign, you ask the patient to lift one leg off the floor. And if this musculature is weak, this pelvis will drop down. So again, we're testing the integrity of this musculature right now. And you can do that for up to 30 seconds, but if they have pain or you see a change, you can end it as soon as you see that. You would then do the next leg the same way. Again, now we are testing this side, and if this musculature is weak, this pelvis will drop down. And again, you can do that for up to 30 seconds. You have the patient put both feet down. Next, we'll be looking for any pain in the posterior elements, specifically a spondylolysis. And to do that, it's called the single leg stork test or the single leg hyperextension test. So you have the patient lift their leg again. You need to prepare to support the patient, and you actually ask them to extend back. And you're looking for any pain or discomfort. That would be more immediate. You don't need to do that for a long time. And then switch legs and do the same thing. And again, you're looking for any posterior element pain, specifically for a spondylolysis. You can ask the patient to put their shirt back on. Then we will move on to our neurovascular testing. You ask the patient to have a seat on the examination table. For the lumbar, we're looking at the L4, L5, and S1 nerve roots, and we will test the strength, followed by the sensation and the reflex. For the L4 nerve root, we're looking for the anterior tibialis. The best way to test that is have the patient try to dorsiflex their foot and see if you can resist that, and you're going to compare both sides. And then for the L5, we're looking for the external hallucis longus, which is the big toe, and you ask the patient to raise their big toe or extend that. And again, you would compare both sides. And then for the S1, we're looking for ankle inversion from the perineals of the fibularis musculature, and you're going to compare both sides to each other. So we just did L4, L5, S1, the strength. Then that would be followed by sensation. For L4, it is the medial aspect of the foot, and you ask the patient if they can feel that and if it feels normal from side to side. For L5, it is in the middle of the foot, and again, you're testing the sensation there, and S1 is on the lateral aspect of the foot. So again, we just did L4 musculature, L5 musculature, S1 musculature, L4, L5, S1 sensation, and then we'll do reflexes. For our L4 reflex, it's the patellar tendon. There is no L5 reflex. S1 reflex is the Achilles tendon, and you actually need to hold the foot and put the ankle in about neutral, and you give a firm tap on the Achilles tendon, and you're looking for reflex. And remember your grading of reflex with a 2 being normal, 0 being no reflex, and then 4 being clonus, and 3 being hyperreflexive. We've now just completed inspection, palpation, range of motion. We did a couple special tests to include the Trendelenburg sign and the single leg stork test, and we've now completed our neurovascular strength testing. We will now go on to the rest of our special test. Next, we'll do the slump test, which is one of our tests for lumbar radiculopathy. The other test that we do is the straight leg raise. To do the slump test, you flex the neck, you'll bring the leg up, and that will put tension on the lumbar nerve roots, and you're looking for any reproduction of their radicular symptoms, and you would do that on both sides. Then we would lay the patient back down. We'll be looking for the straight leg test, looking for radiculopathy. And to do that, you have the knee in extension and you simply raise the leg, and you're looking to see if there's any discomfort, specifically if there's reproduction of radicular pain going down the back of the leg or the side of the leg. And you bring that up really as far as you can and asking the patient what they feel, and you can do that on both sides. So again, and that is the straight leg raise. And then next we will do the Patrick, our figure of 4 test, also called the Faber test for flexion, abduction, external rotation. You can actually put a little bit more stress on that by putting a hand on the medial aspect of the knee, then stabilizing the pelvis, and you're looking to see whether they have discomfort in the sacroiliac joint or in the hip. The last thing I'd like you to do is to do a leg length, and to do a leg length discrepancy, you have the patient bend their knees. You fix their foot to the table. You have them raise their buttocks up in the air, bring that back down. That resets the pelvis. You can get a gross example of both medial malleoluses are lined up, and then you actually can do a measurement. We're going to be measuring from a fixed bony point to a fixed bony point. That would be for a true leg length discrepancy. I find the anterior superior iliac spine, and then I go down just to the bottom of the medial malleolus. And then I compare sides, and I'm looking for a discrepancy of 1 centimeter or more. That would be a fixed leg length discrepancy. Then you can have a functional leg length discrepancy, and from that you measure the umbilicus down to the medial malleolus and compare sides. And again, you're looking for 1 centimeter or more of discrepancy. And that would complete our examination of the lumbar spine.